Oh, yeah. Let me introduce Denis Lapa from Sao Paulo, Brazil. I think she's ready. Maybe, Denis, welcome. Everything is fine in Brazil in terms of COVID-19? Unmute yourself.
Sorry.
Yes. Right. Then I'm sure
Thank you.
very careful not to touch anyone. Everywhere there is a high risk for having COVID-19. We do have new life. Then I wish you all the best. Right. Would you like to try to share your presentation?
Yes.
Excellent. Super.
Can you see it?
Very nicely. Can you make it present? Yes, that's fine.
Yes. So that's it. Thank you, everyone, so much. I'm sorry to be a little bit late, but apparently my calendar doesn't know there is time difference in the world, so I'm very sorry. I was expecting you in 3 hours. Anyway, situation in Brazil is not as bad as it seems. Of course, we are having a very hard time. But you know, news, they sell when there are very bad things to say. Indeed, in São Paulo, we had a very mild situation because we have been preparing for that. So we never had 100%, we had never had a collapse of the system in São Paulo. So I'm very safe here. Anyway, we have beds for everyone. We are not seeing people dying in the streets or don't have places to bury them. The disease is very bad, and we are a large population. But I can tell you that New York lived something worse than here, much, much worse. So,
Yeah.
we are a large population. So you see, that's my alarm.
Denis, very good to see you.
Very good to see you too, Prof. And I will start.
Of WAPM. Actually, we were discussing to organize World Congress next year in Sao Paulo. Then we can discuss later on because the one PCO suggested to make it in Sao Paulo, but we can have a chat later on. Carry on, please. Welcome.
So thank you so much for having me here. I have to start reminding people how do we classify and how do we look for spina bifida. Just keep in mind that in a normal situation, we have the dura mater, the bone, and the skin. Once you have a spina bifida, bone is going to be missing, and that's how we count the height of the defect. Through this missing bone, we are going to have the spinal nerves bulging through the skin, and there is not even meninges covering the defect. So if the defect is in the spine, why it's so hard to see sometimes? Of course, here you have a good position, a good transducer mother that's not that fat. So what you have to look for from the ultrasound point of view is each vertebral body has a posterior process associated. So if you can see where the defect starts, you see here, this is L5, this is L4. So we have vertebral body and the posterior process up to here, more or less. So L5, S1, so this defect starts at S1. But this is a haxkaisis, so there is no bulging defect. The defect is flat. So it's very challenging, although we see the bifida of the spina bifida, we can see that this defect is hard if you are not experienced. And even when you are experienced, if you don't know about this specific type of spina bifida, all of us know about the bulging one, but haxkaisis are a little bit more rare, it's important that we have other markers. So Professor Nicolaides, like a long, long time ago, described the brain aspects of the spina bifida. So to be an open spina bifida, you have to have leak of CSF through the spinal defect. So if you have this leak, you are going to have something called hindbrain herniation. It's translated in the brain by the lemon sign, which is this shape, the altered shape, because as the structures are being pulled down the spinal canal, the shape of the skull changes, and the cerebellum has this funny aspect that's called bananas. I'm not sure why, but apparently sonographers like to name things regarding to food. So I don't think we have enough food. So I just want to explain a little bit about the CSF flow. The CSF is produced by the lateral ventricles. It goes to the third ventricle, then aqueductus, then fourth ventricle. From the fourth ventricle, it leaves the ventricular system to go to the subarachnoid space through these very, very tiny holes here. So the fluid is going to be around the brain and absorbed by this sinus. And this is the fluid that goes to the spine. So if anything happens, as for example, the spinal leak of fluid, you have like a sink effect. When you take out the sinkhole, the water goes very fast down. And so that's what happens with the cerebellum through the foramina of magnum. Cerebellum goes down and compresses the fourth ventricle, the aqueductus, and there's no water around the brain because everything is leaking down. Let's see if we can see here better what happens in the system. So cerebellum and hindbrain goes down to the spinal canal, compressing and giving the increase in the ventricles. And this is kind of a paradox because there is ventriculomegaly, but the brain is dry because the fluid is leaking. So you have microcephaly also. Going back to the spine, I want you to see why it's so difficult to see the Haxkaises. So here again, we can see the vertebral bodies. We have here S5, S4, S3, S2, S1, L5. So this defect starts at S1, and you can see the spinal roots almost surfacing, but still in the canal. When in this defect, which has this aspect, this bulging aspect, you can see the spine surfacing the defect, the bubble with CSF, and the spine going out of the canal. So the height of the lesion is almost the same, but the nature of the lesion is different. So the nature of the defect or of the consequences are going to be different. Because in this defect, we can see the nerve roots are in place. There is only the lack of coverage. And here you see the spine is going up, so the nerves are stretched. So this is a myelomeningocele. This is a Haxkaises. So here you can actually see that there is ventriculomegaly associated with a dry brain. You can see there's no fluid around the brain because the fluid is leaking down here. And this is a very important aspect because if you try to classify the severity of the defect by only looking at the ventricles will 80% of the time be enlarged. And this doesn't mean a lot. It means some things, but not a lot. So the typical aspect is this one. You have the hindbrain herniation through the foramina. You can even measure here. Nowadays, you can do it by ultrasound also, but we are starting to see how reliable this is because the MRI shows you in a much better resolution what's going on. So there is large ventriculomegaly, but no fluid around the brain. It's important to understand that because when we go to the first trimester, the situation is absolutely the same, but the structures, they look different in the first trimester. In the first trimester, you have the brain stem, you have the choroid plexus of the fourth ventricle, and you have the cisterna magna. So these things are very different, but the effect is the same. So many markers have been studied to diagnose spina bifida in the first trimester using the brain science. The same we have been doing for the last 40 years. Because again, in the spine, it's difficult to find the defect, but in the brain, it's always there. And on top of that, you only have indication to repair the defect when you have hindbrain herniation. So you have to look for the brainstem, for the fourth ventricle, for the posterior fossa, and the choroid plexus here. The same place where you see the nuchal translucency is the same place where you have to search for the brainstem and the posterior fossa. So, although the names you don't need to understand, you have to understand this difference between the fourth ventricle, which is the intracranial translucency, from the posterior fossa. And again, when these structures are normal, you can easily see. But when they are abnormal, we have a problem. So that's the fourth ventricle. That is it, intracranial translucency. But you see here, there are two white lines before the posterior fossa. If this is going to be compressed and displaced down by an open defect, these two lines are going to be one. And that's why it's so hard to teach people the differences. I hope I can show you later on. So, although when you have the two images side by side, it's kind of intuitive where to look for, and especially if you have a fetal medicine person scanning that is used to the posterior fossa, it's fairly easy to say, here is the intracranial translucency, and in between two white lines, and there's a black line here. This is normal. Here, you cannot see the two white lines very distinctively, but you still have black spaces here. So this IT, this intracranial translucency, is a very good marker. No one doubts about it. The problem is how reproducible it is. So later on, after the intracranial translucency, Professor Nicolaides in 2011 described these lines as an attempt to show how to measure and what to measure. Again, very straightforward when you have one normal and one abnormal in the same figure. It's clear that there is an increase in the brainstem because you have the shrinkage of the fourth ventricle, choroid plexus, and posterior fossa. And so the brainstem enlarges and this portion shrinks. So for a normal fetuses, this distance is 1/3. This difference is 2/3. Again, very easy, very straightforward. Why we cannot reproduce that in real life? There are other markers of the brain situation. Again, very straightforward when it's normal, and the crash sign when it's not normal. I won't bother showing you this because this is obtained by very, very experienced operators, and believe me, in real life, it's not that easy. And that's my concern when we talk about these markers. Real life is very different from a presentation. And when you have a normal beside an abnormal, it's also, again, easy. But we have been trying to look for those markers. We can now say that with a high-skilled sonographer, you can have even the spinal defect devised, even in a defect that looks more like a haxkaisis than a bulging defect. But again, the brain is easier. So we have to keep in mind that we have here the brain stem in a normal baby, and you have here 2 white lines. The first white line is what makes you mark the brain stem. The second white line is the choroid plexus. So the intracranial translucency here is normal. And if you trace a line, you will see the 3/3 effect. So from the base, you can see, you can trace a line to the first line and then to the bone. But there are other white lines here that confuses unexperienced sonographers. I like these images that are available online, showing, because for an unexperienced operator to understand these signs, it's very important that it has images to compare to. So here you have an actual baby, and you can see here the drawings. So if we could paint in real life these structures, it would be easy for everyone. The problem is, in real life, we don't have drawings, we don't have normals besides abnormals. It's a rare condition. So we need to find out a better way to detect that people can apply in practice, because believe me, all markers are good. So what you have to see, and I'm going to stress this point a lot, it's the brain stem diameter. That's what is affected, and you can use your calipers. You don't need to put lines or draw colors or draw structures. You put one line in the bone, then the second line in the first white line, and the third line in the occipital bone. Forget about these other white lines and black lines that are in between. Just look for the first one. So this is normal. This is clearly abnormal because the white line is further down. It's not a little bit. The ratio inverts. So now you had 1/3, you have now 3/3, and you can measure that. So why people do not measure, why we are still struggling with this sign? While we are struggling with that sign, other signs come up, very good as well, very good sensitivity, good specificity. But again, when you have the colors, when you have the drawings, it's much easier, because to put a line here, anyone can do. To obtain this image, it's very hard. So if you forget, please, the colors, the lines, look for the base, the bone, brainstem first line, and occipital line. Forget about everything here. If you were going to draw a line and measure, where would you measure? From here to here, from here to here, and then from here to the first white line, huge difference. Just put your calipers, please try to do it tomorrow. You will see how easy it is. The problem is that in real life, although nuclear translucency does not vary a lot with the quality of the image, some patients are fat, some babies are not in the best position to obtain everything in the best option, in the best view. So I'm not saying you should forget about getting a good view. No, it's not that. You can see that these nucleotranslucencies, although they are not MFM Fetal Medicine Foundation approved, they happen in real life. So can you see here the first white line, the brain, the bone, first white line, and the bone here? So just put your calipers there. The same thing here. Once you are used to that, it's very straightforward to imagine that this distance here is bigger than the distance here, and it should be the opposite. So please, people, this is real life. And for real life, all the white structures are very hard to see. But if you focus on the first white line, and then you put your calipers and measure first and second at the same time, you will measure, and this is pretty straightforward. This is 1/3 of the measurement. Just please measure it. This is normal, 0.3. This is abnormal, 0.7 is the ratio. So what helps you here is the ratio between the two measurements. The brain, the posterior fossa, the entire posterior fossa, not only the distance between the first line and the last line. Only the first measurement is important, then you measure everything. And then you do a ratio. And this ratio will be normals and abnormals are very different. So, for instance, if you are used to measure I call it the letters soup, the BSOB, the OSBSOB, the ASOB. For me, it's very difficult because I'm Brazilian and English is not my first language. So to use letters, it's very hard for me. But if I can say to someone, measure the first white line and then the entire posterior fossa, maybe it's easier. Let's try and see. Because when you take these two measurements, you have to sum the two measurements to get the ratio. So for instance, here, let's say 3, 6, 3 plus 6, 9. So 3 divided by 9, 0.3. Here, I have already measured the entire posterior fossa. So I have 9 millimeters here in front of me. I don't have to do calculations. I don't have to put anything in charts. I just measure the entire posterior fossa and then same first line to the first white line. 3 divided by 9, it's very easy to calculate 0.3. So we have tried to advise a cutoff. Doesn't matter how you measure, if the entire posterior fossa or you sum the measurements, the line is very obvious. So I believe, Professor, that I'm going to have the 2 lectures in a row, right? If not, please say so, although I'm going to continue to the treatment. So,
Yeah, before doing this one, Dennis,
yeah,
it's to ask everyone if they have any remarks or question about this diagnosis.
okay, I'll
Very,
be ready and happy to answer.
you know, maybe we will have some question for 1 minute. Yeah, very good. Why to use ratio instead of direct demonstration of the defect? Please. Yeah, this was the question, Dennis.
Well, I think I could show you why use the ratio is better than the measurements, because the measurements you have to have a chart.
You mean it's reliable?
It's not only reliable, but the calculation, you don't need to have any normal standards of measurements. You don't have to have a table. You just get the measurement, 9 millimeters, and divide it by 3. The ratio is going to be 0.3. And if it's abnormal, it's going to be more than 0.5. So
Then
you just have to have these numbers in your mind.
very good.
And go on.
But there is one important question. Just to make it clear once, you know, Nejat is asking, Nejat is very active today. Please, once more about first line.
First,
First line.
did
What?
I understand? First line.
What
First line
line?
is what marks the brainstem.
Right.
So,
Is it to see and to look at?
I'm sorry?
Is it easy to look for?
Very easy, because it's the first white line.
Yeah, first.
There's no other white line in between the bone
Yeah.
and the posterior and the occipital bone.
Right. The first line is bounding the brainstem. Is that correct?
Yes.
Right.
Then third line is over the occipital bone.
Yes. Very good.
Yes.
Another question then is, can a closed defect in the first trimester become an open defect in the second trimester?
Wow, that's the question, the hardest question to answer, because the way I've been seeing defects that behave like that in the second trimester. So I have seen defects where you see that the head is small. There is a defect in the spine, but the cerebellum is still normal. And although the posterior fossa is small, it doesn't change the cerebellum. But you measure, I'm going to go for that because I think I have a nice image of that. You measure the brain and you see the head is smaller than it should be. And you do, so you have the defect, you have the dried brain, but it's not complete. So I believe it can change.
Right.
And I've seen some cases where we did not perform the operation because the cerebellum was normal, although we could see the defect down there. But later on in pregnancy, the cerebellum went down.
Very
So
good.
I can say it's possible, but I have no data yet to say for sure.
Right. The one more question, last question, Dennis. What is the difference, you know, actually for the prognosis of spina bifida diagnosed in first trimester and second trimester?
I think the prognosis is much more related to the level of the defect, the anatomical level, and the type of defect. So only in the second trimester, I can answer now this question. And I hope in 4 weeks, we will have our entire database analyzed and some regressions to be able to answer your questions. So wait for the next talk in 1 month.
Very good. Then I'm asking Zalal to direct his question, or just if you do, yes, very good. This is the best way for you. Go.
Hi, Denis. Hi, Denis. How are you?
Hi, I'm fine. I'm happy you are here.
Last
How are you?
Last time we met in Istanbul. It's now in Zoom.
Well,
We'll manage.
we have to wait for next year. I hope Professor Schat brings us together again.
Right.
I hope so too. You misunderstood my question. I didn't ask about the difference between the ratio and the measurement. I'm asking now why to use measurements, ratio, etc., instead of visualizing the direct lesion by ultrasound, not the measurement in the like the IT, etc.
Okay, now I understand your question. Really, the defects that matters and that are prone to surgery are the ones where it's obligatory to have hindbrain herniation. And for an unexperienced sonographer, I think brain is the best place to look. But you are a very experienced sonographer. So for you, of course, it's easier to go to the spine. But remember, not everyone is like you.
Very good. Valentina, welcome back. Would you like to direct your question directly to Denis? And if I see you, you were trying to, where is, yeah, Valentina, are you there?
Yeah, I'm here.
Oh, welcome back. And again, yeah, ask your question. Yes.
Thank you. I would like to ask you, in your experience, the use of high frequency probe could change the aspect of the brainstem, because the brainstem with these new probes appears echoic, not anechoic. And sometimes I've noted that colleagues are problem with this to interpret the images.
So I have no experience with high frequency ultrasound. And again, my concern is for the regular sonographer that's going to be screening these patients and don't have the ideal machine or the experience. If we teach them simple things, although I'm not saying we should not teach properly for them to get those images. I'm just saying that in real life, sometimes they have 15 minutes to do the ultrasound, and to look for these signs is very straightforward. And once you have seen one case by yourself, you will never miss it again. That's my experience here in Brazil. I've been teaching people to look at this sign, and it's amazing how diagnosis is increasing. I hope that in the near future, we will have data to show you that, but try it.
Okay. I think we stop here and we can continue after the second talk. And then, it is better to start. Yes, please carry on.
So I will just show you some images that I took from the next session, just to remain in the brain. Now that we have the opportunity to operate babies in utero, the most striking effect of surgery so far is the reversal of the hindbrain herniation. So I'm going to start with my first case. This is a fetal MRI. This was done at 25 weeks when I operated this baby. And you can see the herniation of the cerebellum through the foramen of magnum going into the spine. You can see the dried up brain and the funny aspect of the cerebellum. 4 weeks still in utero, you can see the dramatic change of the hindbrain herniation. So the cerebellum goes back to the normal. Now you can see the fourth ventricle. You could not see the fourth ventricle here because it was compressed. You can see there is fluid around the posterior fossa. Here we did not have any fluid, and we can see fluid all around the brain, whereas here the brain was right. So for a long time I've been criticized that the kind of repair that I do does not provide a watertight closure of the defect. And I can show you that since case 1, this was our first case, we had the system closed 4 weeks after surgery. So you don't need to put stitches to get a watertight repair. And we can also see the effect of surgery in the size of the brain. So the cerebral circumference is always in the lower segment of the curve. And after surgery, 4 weeks after surgery, it increases and goes to normal, proving that this system is closed and now the head has the normal size. So this is to compare the effect of surgery. This is a spina bifida baby that was not operated in utero. So the cerebellum keeps going into the spinal canal. The cerebellum never recovers the normal aspect, even when the defect is correct, because now the skull is much more tough and the modifications cannot happen after birth, only prior to birth. So the left image is that baby, my first baby, after birth. You can see everything remains normal. Fourth ventricle, normal cerebellum, and fluid around the brain. So here is the difference when you operate before birth and after birth. So from lemons and bananas, 2 years ago, almost, we added chickens to the equation. So now we are training in chicken to repair spina bifida and get rid of the lemons and bananas after surgery. So this is my this is the gift that Professor Nicolaides gave to me, the honor to be doing that with him in London. So, as I told you, next publication soon. Sharing screen has stopped. Let's go back. So, I believe all of you know about the MOMS trial. MOMS trial proved that when you operate a baby inside the uterus, it's better than operating after birth. They compared this in a randomized controlled trial that was stopped because of the efficacy of the prenatal repair compared to postnatal repair. So this study was wonderful. It showed that there is 50% chance of having to put a shunt to treat hydrocephaly after birth when you have prenatal surgery, and you double your chances of ambulation. So, wonderful for the fetus, but MOMS trial used the open fetal surgery approach, which for us obstetrician is counterintuitive, and I think all of us could envision that this would end in favor of less invasive procedures. So the reasons are obvious for obstetricians, but the challenge was to change the neurosurgical technique to correct the defect and the way to get to the defect. So in 1998, Professor Nicolaides came to Brazil, and I was encouraged to move forward, trying to find a way to do it. I started in the animal laboratory. I stayed for 14 years experimenting different types of surgery in the animal model, so we could only then move to the humans. So we studied a biocellulose to protect this the spinal cord, and we have seen in the sheep that this biocellulose has the ability to induce the formation of this fibroblast layer of cells that will have an anatomical continuity with the original dura mater. And this is what gives the watertight effect of this repair. We don't need to put stitches in the biocellulose because the fetus itself produces these fibroblast layers that closes by itself the defect. So we have to keep in mind that the fetus is producing all the tissues, and it can fix some things that are not there by itself. So again, challenging cases, as I told you, hard to diagnose and hard to fix, because here we don't have enough skin to close the skin after placing the biocellulose. So we studied an artificial way to do it. There's large experience using these relaxing incisions after birth. They work very nice when the baby is born, but in uterus, since the year 2002 people, we know that this is not true. So this was published in the year 2000, before the MOMS trial, showing that these relaxing incisions inside the womb give a very bad, not only cosmetic, but functional scar. And after 18 years of knowing this, we see people using them and saying, no, it's not that bad. As we were in the lab, we had the time and the patience to look for alternatives. We now use this artificial skin in these cases. It's about 1/3 of the cases. And we have these results after our learning curve of 20 cases. We are now using a kind of artificial skin that when the baby is born, the skin is almost all healed. So we never use relaxing incisions. We compared this new technique of only placing the biocellulose and closing the skin to the MOMS technique, where the neurosurgeon closes the dura and the muscle and the skin, 3 layers. And we have shown that when you do biocellulose and don't put stitches, you have far better results than when you put stitches to get the watertight effect. We have done a pilot study. We used general maternal fetal anesthesia to repair using a fully percutaneous procedure. We called SAFER. It's a fetoscopy, but we have to use 3 trocars, and now we are using even 4. Our results are getting better and better. In the beginning, we had a lot of PPROMs. I still go to meetings and see people asking me, it's impossible to do an anterior placenta. So I still get a little bit frustrated that these people believe I'm lying, but I'm not lying. We can do it in anterior placenta. You just need to figure a good way to do it. So these are the images that we get using CO2. It's a different fetoscopy from operating under the water. We can now dissect the placode as good and as much as any neurosurgeon after birth. We are now using the SMILE facial flap, which absolutely changes all our results because it provides you with a extra tissue to cover the placode. So not only the biocellulose is protecting the placode, but now you have these flaps that are covering the defect. So we place the biocellulose, but we give an extra tissue. So now we have much more protection, much less leak, far better skin scars, and we are still under 3 hours of surgery. Of course, this needs training, but you see, we don't need any relaxing incisions, and we have a very nice myofascial flap. Now we can use the artificial skin that we have been studying for a long time. Now this new artificial skin allows us to use barbed sutures to fix the skin, and the result I just showed you, this silicone layer remains until the baby is born. Then you cut the stitches and this silicone layer drops by itself, and there is now a new skin underneath the silicone when the baby is born. So with the myofascial flap, we changed the results in so many aspects, and that's what you are going to see. So people is still considering anatomical level as a cutoff, but I can say that this clinical evaluation can be done by ultrasound. And I'm going to try to stress that here. So this baby has an L4 anatomical level. So it's a very low level, but the motor level of this baby is L3. You can see there's flaccid paralysis when this baby was born. We could see that in utero. And we have now this other baby that has absolutely the same anatomical level, but was born with motor level S2. So one is in the wheelchair and the other is jumping. So we cannot rely only in anatomical level to determine inclusion criteria. We have now to move for motor level, and we can see motor level. This is described by Elena Carreras. We can have absolutely the same evaluation we have after birth. So L1 is when you have a good hip flexion. L2 we cannot see by ultrasound, but L2 and L1 are almost the same functionally. L3 when you have knee extension. So in Brazil we say kick the ball. L4 is when you can bring your foot close to your bottom. So kick and retract. L5 is when you have movements in your feet. S1 when you are driving a F1 Formula One car. You have the gas pedal sign. So you see, we are all Brazilians in these movements. So this baby is not only kicking and retracting, but doing the gas pedal, which is the foot extension. So I hope the video works. We can see that using not only 2D, but we can use 3D. And we can determine, no matter what is the anatomical level of this baby, that the motor level is L5 bilaterally. This baby cannot do the gas pedal. It kicks, it retracts, it puts the toes up, but it does not do the extension of the foot. So we can see this very clear. Examinations take 7 minutes for you to get all these movements. And if the baby doesn't have all movements, you can pretty rely on that. And you can know if this baby is going to walk or not, because L3, L4, L5, S1, usually they walk. So our numbers were very criticized in the beginning because we had 32 weeks as mean gestational age of delivery. As I told you, myofascial flap and humidification of the CO2 changed this dramatically. We now have 34, 35 weeks as mean gestational age of delivery, and we have half the PPROM we had in the beginning. So we have now 40% PPROM. I'm going to show the results of our latest 82 cases. Woo. Should I start the pool? Prof? We lost the connection?
Did you lose your connection?
No, I have connection, but just that the pool appeared for me here. Can I continue?
Oh, yeah, for a more, yeah, let's ask participants how many minutes you are asking to Dennis to continue.
We are done with time, so no worries. I'm going to dump to the end.
If you like, because everyone is happy.
Would you like me to continue?
Yes, you can continue more minutes because everyone is happy.
Okay. I just love so much the topic that time passes flying. So by June last year, we had operated more than 100 cases. This year, we have already reached 117, but I'm going to show you only the results of the latest 82 cases from last year. I removed the first 20 cases because that was our learning curve. So these are the results, and I'm going to update them very soon. We can allow vaginal delivery with our fetoscopic technique. We have almost 9% of the babies having complete reversal of hindbrain herniation after surgery. We have the same shunt rate as the MOM trial, which is around 40%. And we are now not only doing shunts, but we are doing also ETVs, which is a far more better procedure for these babies. We have managed to improve neurogenic bladder. The moms never showed any improvement in neurogenic bladder. Moms had almost 70% babies with neurogenic bladder. And now I'm going to go back to the neurogenic bladder guy. We have a different situation now. So I completely agree with the protocols you use for postnatal repair, but for the antenatal repair, we might be more conservative. That's our experience now. We are doing this for 7 years. We have lots of data that's going to come out soon. So in our cohort, we have 20% of babies only catheterizing, but we use the conservative approach, not the active that you have shown. Regarding ambulation, we have 61% of babies in our cohort ambulating without any orthotics or assistive devices. So we are having also different and better motor outcome. I'm going to put all these numbers together with the moms. And we are seeing babies improving even when they are born with very poor motor function. So here you see that baby that was in the wheelchair now is able to stand, and she's 5 years old now, and she is beginning to be able to give some steps. So people have never seen this in the old spina bifida, I like to say. When a baby was born with flaccid paralysis, it would never recover anything. And now we are seeing different things. So to finalize, mom's postnatal group had 80% need of shunt. Prenatal group dropped it to 40%. We are almost the same. This difference is not statistically significant. Walking independently, like I just showed you, mom's prenatal was 21%, doubled to 43%. Now we tripled to 60%. Catheterization, the same, 51% in the prenatal repair group, 38%, no statistical difference here. Now we have 20%. And one final, but I believe it's going to be the most important aspect in the near future, is mom's postnatal had 1% surgery for tetragorg. It was 8 times more for the prenatal repair, and we are having half of that. So I think the future holds a different things. Improvement in ultrasound now enable us to see in the repair group the neodura mater, the motor neurons, the skin, and we can even do pathological anatomy in humans now. So, Professor, this is to finish. I can make some comments about other techniques, but I have no doubt that the future relies here. We have now taught the technique in 5 other countries. Until this month, we have now a total of 51 cases done outside Brazil, and we are having the same results. So it's reproducible, it's good, and we are going to have even better numbers soon. Thank you so much for your attention.
Thank you very much, Denis. That was great.